it's recorded. There was only a few questions on the infographic, which I was surprised to find in a different place, unless it's just me. So I hope that everyone who is listening in on the replay who had a question had a chance to put it on the graphic. So I'm going to answer the ones that are there. And since we don't have too many, I'll take I'll take some time to maybe dive into some of these, some of the ones that are here, because there was a common theme amongst two of them. We'll let Cindy in. A common theme amongst two of them, and we can kind of just go over a bunch of different things and see if we can be helpful. So that might not be something that you're directly, the direct question that you would have asked, but maybe I'll hit on a few different things that might ring true for you or might not. Maybe none of it, but if it brings up more questions, then of course throw them in the app group if you're in the app, then the Ask a Doc group, or and anywhere in any of the groups, and tag me and I'll be sure to find it. We'll get Natasha in here as well. So guys, as you're joining, I was just saying there isn't too much going on the graphic. So if you want to put anything in the chat, we can chat about, go for it. I'm here for you for as long as you need me, up to an hour. But that is all fantastic. So I'm going to go through the graphic. And Carrie Ann, I got to, Carrie Ann's the question that actually also relates to, very similar, in fact, to Jessica's question. So Jessica and Carrie Ann, if you are listening, I'm going to try to loop both of your questions in, but then I'll go back and make sure there are some specifics in your questions that I go over. And Carrie Ann's question came up twice in two different places. So it sounds to me like a woman who needs all of our help. So any suggestions that you want to go on and put in the chat box for Carrie Ann, I will be happy to read out aloud so that she can hear them back on the replay, because I don't know if she'll be with us tonight because I haven't seen her yet on the call. And the Ask a Doc group is working out really well. So if you are on the app, I think it's a really great way now for me to find the questions. I asked Kim and Laura if I could have my own little group, because the way that the tagging works in the app community, it makes it really hard for me to find anything that you guys might need me for in there. So I love having the direct group. I just go in, I know where to look, and it works out fantastic. So Carrie Ann had put this question in both places. Please go for it, Natasha. Any other questions that you have, ask them right here in the chat box. That's the beauty of being on here live with me, that you also get a chance to ask right in the chat box. So if you want to go ahead and type it out, I'm going to start with Carrie Ann's question. So Carrie Ann's question is, Dr. Rachel, I've been so tired lately. She's on HRT for 2 years now. She's 55. She says, when will I get my energy back? Seems like I never get enough sleep. And like everyone else, I'm in a fast-paced job, too many hours to count. She's a nurse case manager in a community hospital in Los Angeles. So looking at the time, Carrie Ann is probably still at work because it's only 4 o'clock in Los Angeles right now. So she might still be at work and might catch us later on tonight or on her drive home. And this is a really common question. If you guys have noticed that the sleep issue has come up a few times, but she also wraps in here the sense of frustration around, well, feeling like you're doing all the things. You start the hormone replacement therapy and you feel like you're listening to all the advice, you're ticking all the boxes, and why does it seem like it's not some magical thing and overnight you feel wonderful because you heard your friend say, oh, I started hormone replacement therapy and overnight I feel wonderful. I also want to mention that because Carrie Ann gave me a little bit more detail on her question in the Ask a Doc group. It was essentially the same question, but she feels like she needs 10 hours of sleep, but in reality, she only gets 7. And I only want to mention that too, because it'll kind of come into this more whole encompassing answer that I have that might be some things that hit for several different people. Takes her almost an hour to get motivated to exercise. She also asked just to the group, anyone else suffering, and how long will this last? So this is a really good question, Carrie Ann. And I would also say there's a whole lot of things in your question that I'm sure a lot of people can relate to. And you might also be able to recognize that, of course, it's not always just one thing. And sometimes when it seems like you're doing all the right things, you still feel like it's not quite going your way. And I just want you to know, Carrie Ann, that I'm sure that a very high percentage of people either feel exactly like you do right now or have at some points in the last X number of years. And I think that that's because a lot of times all of these feelings or this sense of not being able to catch up, not being able to sleep well, not being able to get enough sleep goes in cycles throughout your life. And it might just be, Carrie Ann, that it's more the cycle of your life right now rather than just the menopause, or maybe it's all of those things together. So I was thinking about kind of the feeling of sleep deprivation or being really fatigued in myself, and I was trying to feel like something that that helped to relate to all this. And so I would say that for myself, I feel the same thing throughout a year in different cycles. And that will have to do with what I'm doing with my career at the time, and very importantly, what I'm doing with my diet and exercise. So you have to look at all of those things and how that can be playing into how you feel. I know the feeling of how it is when I'm shredding. And I know, Carrie Ann, that you've been dieting with the groups for a while, and you have to, I think, take some account of how you're feeling and how that's affecting you in your day to day in the stage of the life, in the stage of life you're in right now. Because everything has ebb and flow, and you want to take all of these different things into account. So my advice to you, Carrie Ann, would be kind of start at the top with the basics. What are the calories that you're working your plan on today, on these days? What is your plan right now as far as your health and fitness goals? Are you trying to shred? Are you trying to build? Are you giving yourself enough fuel for the goals that you're trying to accomplish? So if in some way, just you want to look at very, very basic, look to the fuel that you're giving yourself for the day. What are you trying to accomplish? In what time frame are you trying to accomplish it? And is that something that you can adjust for how you're feeling right now? So if your goal is a particular thing and it's short-lived, then you might actually have a short-term goal that's sacrificing your sleep, and that's just a matter of making the decision whether that's worth it to you. So I certainly know for myself with my own physique goals that I will have periods of time where I know that I'm running myself a bit thin, and I know that that's going to sacrifice my sleep quality, but it's typically for a short period of time. So look also to Carrie Ann to what you're doing in your diet and exercise program with your physique goals, and are there competing interests? So, we expect to start the hormone replacement therapy, sleep like we did when we were teenagers again, and wake up feeling refreshed because we're on hormone replacement therapy. But we have to remember going back to the basics, because I could tell you that I take a lot of hormone replacement therapy, and when it comes down to the end of a shred for my own physique goals, I don't feel like my sleep quality is good. And that could give you a lot of fatigue during the day, but you just reflect back and kind of where it's coming from. So I would say, Carrie, I look to what your physique goals are right now. Are you getting the fuel? Is it worthwhile? Is it working for you in this stage of your life right now? And maybe it's a time where you want to actually boost up your nutrition to help you to get better recovery, to sleep better, to feel better during the day. So more than just your hormones, think about your recovery and how you're doing all the things. So that would be that. Then you want to look, of course, Carrie Ann, at your exercise, because again, right, we're talking about our hormone replacement therapy and menopause and how that affects our sleep, but also remember how your exercise program and how much recovery you're giving yourself is going to play into how you feel during the day. So perhaps some of the extreme fatigue that you're feeling has to do with not giving yourself enough recovery time. And I do realize the circularity of that argument, because if you're not getting enough good sleep, you're not getting a good enough recovery, which brings you back to step one. How are you fueling your program and to get good recovery so that you're sleeping well? Again, sometimes those are competing interests, but you just have to know that you're playing one versus the other, and for a short term goal. But I'd also encourage anybody who's feeling like, they've really looked to their basics and they're covering all their bases, to consider also, speaking with a primary care provider about perhaps even optimizing your vitamins and minerals levels. So, sometimes we'll forget about things like enough magnesium, zinc, calcium, all of those things as we're focused on optimizing our hormone replacement therapy. We also want to make sure that we're getting all the nutrients that we need. So, certainly is something that, once you've kind of looked at the basics of what you're doing, your diet and your exercise, also going to a provider and perhaps looking at some nutrient deficiencies might actually be playing into your recovery and into your fatigue. So I never want to think, everybody kind of bypasses those things. So Kirian, I certainly would encourage you to also consider whether you're getting enough micronutrients. So magnesium, vitamin B, and those things. Importantly, vitamin D. So if you're not getting enough vitamin D, you may feel some fatigue. So you just want to make sure that you're optimizing that stuff as well. And then certainly, of course, I think we've talked about a few times on the call, it's just optimizing your sleep schedule. So that helps you to get good sleep, and that starting first thing in the morning, that by, um, getting up in a time that works best for you, being very consistent about your waking and sleeping times, having a good routine in the evening that calms you down for good night's sleep, looking at how perhaps different times in the evening that you eat play into how well you rest at night. So some people, if they eat close to dinner, will struggle with their digestion throughout their sleep, or their metabolisms, or they're digesting the food over the night in their sleep, and they're not getting enough time to actually rest. And that can play into your recovery and your sleep quality overall. So you certainly want to look at those things as well. And that takes a little trial and error also for what works best for the individual. Because like Kim always says, she can't go to bed hungry. She has something before she goes to bed. But if you eat a meal sometimes too close to bed that maybe has too much sugar in it, then you might get poor sleep that evening. Certainly, if you're somebody who drinks alcohol, you might find that that also affects your sleep quality. So you could, in fact, be in bed for 7 hours, but yet not feel like you slept a single wink, because you don't get restful sleep when you have some alcohol. So just watch for things that make a pattern, so that you can at least try to optimize the time that you are laying in bed. So those are the things I would say to look for, Carrie, and to see if you can get better rest. And I think that I can sense some frustration in the sense of that, if you feel as though you were going to start hormone replacement therapy and things were going to get significantly better, it could just be taking more time, or it could be any of the other factors that are also playing into your rest and your recovery overall. So I do know that personally, I've spent a lot of time on low calories over the last several years of shredding and the like. But when at a time in my build when I can get up to like 2,400 to 2,600 calories, I really do feel so much better, and sleep quality is significantly better. So again, that sometimes competes with your physique goals because it has its time and place, right? So in the height of a bulk, when I'm on that many calories, I do feel rested, push really hard in the gym and all that. But then if you start to feel a little bit fluffy, of course, we all start shredding again. So it is always ebb and flow. So just look at how any of those things are playing into your sleep quality and your recovery overall. And Carrie Ann, if there are any other things that when you listen on the replay, I can help you with, or any other details that you can help me with that I can give you better advice with, let me know. But when I saw your question, it really was, it did seem to me that it was the perfect thing to have as a more open discussion, because we could go back and forth with a million different questions and things, because all the generalities we could make, and then so it could be more specific to what might be affecting your sleep, because there's so many different factors. Sometimes you really have to dissect your own sleep process to figure out what might be interfering with your sleep. And so before we leave the sleep question, let's see if we can help Jessica with a few more specifics while we're here so we don't come back onto it. So Jessica's question is, she says she's 53 in menopause, but not on hormone replacement therapy, strength training 4 or 5 times a week with some cardio, suggestions for sleeping better, taking magnesium, deep sleep from the Protein Works, which I imagine is a melatonin type supplement. I have to look at the package. 5-HTP and a French menopause supplement called Ergiameno. Energy Meno. So if you just spell it out, LaMonica, you'll get it. And I generally manage to sleep through the night, but I wake up tired. I'm usually in bed before 10 p.m. I try to relax in the evenings before going to bed, try to eat relatively early and have a snack before bed. Same, a lot of the things that we have already talked about, and hopefully I can help. So again, it comes down to going to bed, but getting that good quality sleep. It sounds like you are doing a fair number of good things. I don't know, Jessica, if you are a candidate for hormone replacement therapy. It might be something that helps to add to your regimen. But I would say also, again, as we just said in answer to Carrie Ann's question, maybe looking specifically at some of the mineral deficiency that can relate to sleep and stress. But magnesium is great, checking that level to make sure you're getting enough of it, B12. And the other thing I just wanted to mention so that nobody ever misses this one is when you see a provider, you also want to be sure that you don't suffer from sleep apnea of any kind. So you may consider talking with your provider if you are doing all the things and you aren't getting good recovery sleep, and you feel like you're very tired during the day, even after several hours in bed. It's always worthwhile to consider that you may suffer from sleep apnea. People of all weights, heights, and the like can suffer from sleep apnea, and it can really affect your daytime fatigue. So that's just something to also talk with your provider about, especially if you have a partner who says that you snore. They might not notice if you snore, if they snore louder, but it is good to know if it's also something to be evaluated for if you have daytime fatigue, is to consider sleep apnea. It's really important because untreated sleep apnea can lead to high blood pressure and other health problems. So it's certainly something that you would want to treat if you did find out that you have. So that is also one other suggestion that's kind of non-menopausal related that happens to women of our age in this menopausal time frame, or women of all ages. So you just want to be mindful that there can be things that are going on that have nothing to do with menopause. But that's what I would just make sure that everybody is evaluated for if they think they might need to. And again, Jessica, you may consider a hormone replacement therapy to add to your regimen and see how that goes as well. And Jessica, if I can be any more helpful for you, just let me know. Hopefully you'll catch us on the replay. So that's 20 minutes on sleep. Is everyone ready for going to bed? And I think Tammy added, I wanted to, yes, we'll get this one before we all leave sleep and you all fall asleep on me. Speaking of sleep, Tammy says, is the recommendation 7 to 8 hours? I never seem to get enough. I feel good when I get up, but I'm dreaming but I get nine. Oh, sorry. When I get nine, but I'm dreaming because that's not realistic for sure. So it's actually very individual how much sleep any person needs. Some people can do quite well on short amounts of sleep. There is apparently some genetic variation, fascinatingly enough, in whether people can do better on short durations of sleep. Apparently, there's something with the military and people who are better cut out for like being like SEALs or Navy SEALs or some really drastic maneuvers that some of the gentlemen and ladies in the military do that actually can function quite well on short periods of sleep. Um, but everybody, I think there's no wit test or way to find out if you're the kind of person who needs that kind of sleep, but rather if you have any sleep trackers that might give you a good idea of like what your sleep quality is over if you sleep for X amount of time versus Y amount of time. I think that sure, the recommendation is generally being in bed for 7 to 8 hours. And some people like yourself are going to do great if they get for 9, maybe even 10 if they're very lucky. But some people are actually going to wake up after 10 hours and feel worse. And that's because of, however their sleep cycles are, they're actually going into further into a sleep cycle where they're waking from a sleep cycle and they're not actually feeling better during the day. I typically do well on 6 hours of sleep. I would say I do better on 7 hours or closer to 8 hours of sleep. But I guess that's what has carved my life out to be in surgery because I do function well on short periods of sleep. But of course, like you, it's a complete dream if I can get longer when I got the opportunity. But yeah, for sure. I would say just look at like meeting at least that 7 to 8 hours, which is the general recommendation, 6 at the very least. And if you do find that you do better with the occasional like catch up sleep of getting like a good 9 or 10 hours on a weekend, you might find that helps you to feel better, or in fact, actually just see if that actually makes you feel worse. But all these new sleep device trackers, you can kind of like nail down some of the details that help you. But it's funny because I loved one of the old extreme body makeover podcasts that Mark and Kim had done with sleep, and Mark was kind of poo-pooing the whole sleep monitor thing, saying, well, if I get up in the morning and I feel like crap, I don't need a device to tell me I feel like crap. But yes, if you just tap into your own intuition, you can tell whether you're feeling better with more or less sleep, but to figure out what's best. But general recommendations are 7 to 8 hours of being in bed, because what you'll find is that you can be in bed for 7 to 8 hours, but your tracked sleep can be less than that because we spend some amount of time coming in and out of a sleep cycle throughout the night where you don't wake to that you're conscious of being awake, but you do you do come out of deep sleep into a more wakeful state throughout the night. So that you want to shorten those periods as best as you can by increasing the quality of your sleep. And that's typically by getting into bed before midnight, getting those hours of sleep before midnight, looking at caffeine, alcohol, and other things that can interfere with your deep levels of sleep or your rapid eye movement sleep, and the things that help you with those things that increase the quality of sleep. So we're going to leave sleep, but feel free to bring us back to sleep if you have another question. For sure. So Flannery says, hi, I had an ovarian cyst rupture and it looks like there are 2 more. Anything I can do about that or not really? So Flannery, it's actually pretty common to have ovarian cysts in the perimenopausal period. What happens is that since we're not making as much estrogen, the signal back to the brain is we need to shoot out more of the stimulating hormone, that follicle stimulating hormone from the brain those higher levels of follicle stimulating hormone from the brain stimulate the ovary, and then the ovary will try really, really hard to do what she's being asked, is to make estrogen. So sometimes she'll make these large follicles that the signaling isn't quite right. And then one of those larger follicles, or cysts, as we call them, can rupture. And then the other ones that were also being stimulated can be hanging out in your ovary. And these just will go in cycles in perimenopause, because as high as your levels can be 1 month, and then you finally make some estrogen, it sends a signal back to the brain to stop shooting out all of that stimulating hormone, and then the ovarian cyst will shrink, and then the process will go on and on. So every once in a while, of course, we'll get one that bursts. It causes a bit of pain, over usually over a few day period of time, that resolves on its own, but it can be super uncomfortable because all that fluid goes into your pelvis and it's got nowhere to go, but it needs time to be resorbed. So there really isn't very much that you can do to get rid of them. I always tell patients about 90% of the time they're going to go away by themselves. And most of the time pretty non-dramatically, but every once in a while they go away in true dramatic fashion with some discomfort. But it is just part of the perimenopausal period. I suppose if you're supplementing with a little bit of estrogen, like if you're on perimenopausal hormone replacement therapy, that will decrease some of the stimulation of the ovary. Sometimes we, in fact, will give birth control pills for a short period of time, because it'll do the same thing. It will kind of decrease the stimulation of the ovary, depending on the level of discomfort. Most of the time, we'll kind of just manage them, as we call it, expectantly, and allow them to go away on their own. So there really isn't too much that you can do, unfortunately, Flannery, because this is just a time in our lives where we're kind of hormonally all over the place. But reassuringly, this will all start to ease out over time. But I
And
wish there would be. Go ahead, Flannery. Are you there? There you go.
yeah, yeah, yeah. Sorry. Thank you so much for that. Yeah. It actually was pretty dramatic because I actually passed out from the pain and I ended up going to the hospital because I didn't know what it was. But yeah, it's just, I understand it's normal. I'm 43 and I'm managing fairly well. Like it's getting a little bumpy from time to time and my cycles are not super irregular, but they're kind of short. Like, do you, like if this is happening, I don't really need HRT yet, but like it's in the future somewhere, like how would I know when I really like when it's too much to manage? Is that when I'm looking at HRT kind of thing?
And I'd say that right on. It's going to be very different from person to person how they decide to kind of manage this part of their life. If you're having symptoms of perimenopause, like you said, with the irregularity, certainly is worth talking with your gynecologist or other provider, because there are perhaps things that can be helpful to you. So it's good to know what your options are. At least knowing what your options are and deciding whether, in fact, it's something that you want to do, or seems like it's like palatable to you. It's like, or you're like, I'll kind of wait it out a little bit and see how things go. The thing about 43 or this time of life is that, as crazy as things can be for like 6 months or a year, many times they can also kind of normalize or regulate for a short while and then perhaps
Oh,
go back and forth from time to time. Even so much as being symptomatic with hot flashes and night sweats, they can come in like they can come in waves when you're in perimenopause. But it is
okay.
certainly something that, if you're noticing a decrease in the quality of your life, it's absolutely worth knowing whether there are options for you. I'd say commonly, in someone in their early 40s, it might even be someone saying a low dose birth control pill for a while, because it's easy to kind of manage many of the symptoms. So it certainly don't feel as though, if that's your provider's offering, that that's your only option, but it is a pretty common option. Not they're gaslighting you thinking, oh, just start this
Yeah.
birth control pill, but it is sometimes a good solution in an irregular period of your life, if you're a good candidate for it. But many of us are kind of leaning more towards just like low dose supplementation, if that seems right for you as well, because that seems to be, now we see it as safe and easy and effective to do, for those perimenopausal symptoms. But just know that, if you are having a wacky time and it lasts for more than a couple of months, it is worth talking with your provider about different options that you might have.
You said low-dose supplementation. Do you mean of estrogen that's not
Yep.
oral? Because I was just thinking like oral estrogen possible blood clots, like, I don't know, like, because I know that that's sometimes a factor maybe?
Well, you can get low dose and do low dose supplementation, even in a patch form, so in a
Y
non-oral form. So
Right, right,
the
okay.
the patches go as low as 25 micrograms, which honestly would be not enough to treat menopausal symptoms in a sincerely postmenopausal woman, but it might be just enough. I found in some women who are making their own estrogen but need just a little bit of help. There's a nice low dose option of 25 micrograms, something like that. But it doesn't have to be oral if you choose not to.
Right, right. Okay,
For
cool,
those
thank
very
you.
same reasons, you're correct, is that, you would, there is a slightly elevated risk with taking oral estrogens. It's actually probably similar to birth control. If not higher with birth control. So that's something to consider as well if you are given two different options.
Right, okay, thank you.
You got it. My pleasure. So we'll go over to Oh, yeah, Tammy was saying to you as well, Flannery, that she had the same thing happen to her. So yes, many I think can sympathize at some point during our menstrual lives. That does happen to quite a few of us, and some, unfortunately, I see in the office where it happens to them monthly, which is terrible. And so that's when I really become much more suggestive or highly more recommending to take birth control or something when it's that frequent of a problem. So Natasha said her question is here. She says, "I'm 47 in 2 weeks. Happy birthday coming up." She has Hashimoto's and feeling symptoms of perimenopause. My cycle is still around, however, shorter and heavier. So she also adds that I just got married and my partner and I are still having hope for a miracle baby with the help of IVF. We were aiming to start the first cycle in July. Congratulations. Wow, that's a lot going on at once, that's for sure. Given all this, HRT is not an option for me. To be honest, when you do IVF when you do IVF when you're older, you are being given a whole bunch of different hormones. So it's not so much that HRT isn't an option for you, Natasha, but you're going to be getting a whole bunch of different things. And certainly hot flashes and the cycle stuff will kind of go to the wayside and be replaced with the other hormones that you're getting given artificially. Um, so let me just read through the question, then I'll kind of start back at the top. Been regularly active with yoga, swimming, running, basic resistance training. However, since November, I gained a bunch of weight due to Hashimoto's being triggered. I since changed my diet to autoimmune paleo, which helped. However, now extreme fatigue has taken over. I find I can't make it through the day without needing a 2 hour nap. Poor thing. Taking magnesium, vitamin B, and a few others. Also, muscle joint feel constant inflamed, but too short 2 kilogram walks, which is new to me. Feeling a bit lost, defeated, and my energy and clear mind is back. If I feel this way before IVF journey, I can't imagine even taking that step. Oh, I feel your pain, Natasha. Let's start at the beginning. So it sounds to me, I think, to be honest, mostly whether which comes first, the chicken or the egg, as far as Hashimoto's, for those who haven't heard or understand, is autoimmune thyroiditis. And I'm also saying that because we talked a little, I think, on one of our last calls about how perimenopause and menopause can affect autoimmune disease, or how those stages of a woman's life can make her more susceptible to autoimmune disease. And I think probably, Natasha, what you're getting right now is kind of this perfect storm of the perimenopausal changes triggering your Hashimoto's, because it's very sensitive to changes in your estrogen levels. So, estrogen, as one of our hormones, has anti inflammatory properties. So, generally we keep inflammation low throughout our premenopausal life because we have estrogen levels that keep our for the most part, that keep our inflammation lower. Obviously, if you've had Hashimoto's, there's been periods in your life that are more inflammatory, that Hashimoto's is more active, whether that is associated with hormone levels or not. But whatever triggers those, perimenopause can be an additional trigger to the autoimmune condition. So I would say that for that, if you were looking to just optimize your Hashimoto's as well as your perimenopause symptoms, is you would be looking to things that decrease inflammation overall, which sounds like you're doing by already starting to have hit your, I'm sorry, I think you said anti-inflammatory paleo diet, autoimmune paleo. Yep. So the autoimmune paleo is essentially built on those principles, right? So it's the same principles of having lower inflammatory foods in your diet. Specific triggers for autoimmunity can be dairy, egg, sugar, and gluten. So those are the typical high offenders for most chronic inflammatory diseases, autoimmune diseases, things like that. So following that type of diet should and can also help with perimenopause or menopausal symptoms because it's decreasing inflammation overall, which again, when you have adequate levels of estrogen, is also there to protect you against. So you're just kind of getting the perfect storm of having the things that are triggering your autoimmune with lower estrogen levels. You're also seeing that your autoimmune conditions are more flared up. So, all right, you're like, okay, LaMonica, it's great physiology, but what do I do about it? I get it. So I think you're headed in the right direction by doing the
You're so
autoimmune
sweet.
paleo.
You're so sweet. Thank you. That is totally the perfect storm. As I was writing this, I was like,
Yeah.
just delete.
No,
Nobody needs to
no.
hear all this.
No, for sure. You can feel your pain because, and that this is definitely a common time for
Hmm.
this to happen. And you are really feeling the perfect storm, but it's not in your head. It's absolutely physiologic. But what do you do about it is true is that, it's difficult. You are doing the right things. You have to just find all the things that you do that work best to lower your inflammation. So I'm sure you've had Hashimoto's for years and you got a good feeling on the things that help or that will trigger you and also those things that will help you. So those things that help you to recover. It's easy to say of a newly married woman getting ready to do IVF. That's a lot of
Well,
stress. So
do
you
you
just
think
find
that's
your thing.
insane? Do you think I'm
No.
insane? Given that, like, there's perimenopause, there's Hashimoto's, like,
Yeah.
I could listen to everyone in the world around me and be like, you're insane, stop. And I'm like, no,
It's not
I
so
feel
much
like
that
I'm
you're just
meant to be a
adding.
mama.
Yeah,
Yeah,
you're adding stress, and you just if you find a way that helps you manage that stress,
hmm,
physiologic and psychological stress, because it's all going to be lumped in together, then you
right,
can accomplish all the things at the same time. You just know that that's just yet another trigger. But I think that when it comes to the hormones of the IVF stuff, that's all artificial and secondary, and they're going to have that stuff, biochemistry 101 for you. But if
right,
you in the background do all the things that can help you with inflammation and dealing with that recovery, I think that's going to be just for you the best thing to do. Is that to help you also get the best success from your
from the idea.
process. Yeah, you know what? You don't want to think that, like the inflammation and things in your milieu right now is going to affect your results negatively, but they're pretty
Right.
damn good at it, so they can overcome most things. But
Hmm.
most of the things that the hormones and stuff, your perimenopause is gonna be completely secondary to that because you could get a woman who's menopausal to cycle with the artificial hormones. So that part they can do.
Okay.
It's just a matter for you of managing your own autoimmune diet, the things that help lower inflammation, the things that help you to recover, to manage your symptoms of Hashimoto's, especially that fatigue, the extreme fatigue that comes with all of that.
I think that's what it is that I was like, I know there's the things and I have to be very cognizant of what I'm eating and so on and so forth. I think it's just recently I'm like, wow, how can I not make it through the day without a 2 hour nap? And
Yeah.
then what usually gets me going is like, okay, go out for a walk, oxygenate. But even going out for like a 1 kilometer, 2 kilometer, I'm Canadian, that's why kilometer walk, like I'm sore. Like my legs are just in so much pain. I'm like, how? I used to run 10 kilometers and now I'm just
Sounds like
walking.
mineral deficiencies. So I
Okay.
would say the other thing to be very mindful of is maybe even having those things tested, because if you're getting like literal cramps and such in your legs with that kind of activity, that can be from mineral deficiencies, and that can be also from the Hashimoto's and or contributing to it, because those are
Okay.
the things that you want to look for, like iodine and calcium, magnesium. Those are the things that are going to give you muscle cramps.
Okay.
And the
Okay.
iodine helps to optimize your thyroid function. So you want to look for those things as well.
Right. Okay. Thank
Best
you.
to get, if you can get tested for those different levels, that can really help inform you instead of feeling like going to the market and you're pulling all the things off the shelf and you're not quite
Yeah.
sure what and how much to take. If you do have somebody who tests those things for you, it can help. Diagnose, that can help inform you on how much, and like to keep you from taking things that you honestly don't need. Like, so just
Right.
if you could pinpoint what the vitamin deficiency that you are having that's causing the cramps, that would be helpful.
Okay. So I am taking magnesium and B12. So it would really be when it comes to like muscle pain and like
Mhm.
even joint pain, it would mainly be what, iodine, or what else am
Well,
I
that,
looking
I
at?
mean, magnesium is usually muscle and joint pain. Low estrogen levels
Low
can cause your
estrogen.
joint pain.
But I
Um,
can't do anything about that, right? Is that correct? Because
Not
I'm
really, not
heading
right
to,
now. Yeah.
yeah,
But lowering
gotcha.
inflammation is helpful. But the other thing, even when you're taking magnesium, honestly, it's worth testing the level to make sure you're getting enough. Because sometimes you
Okay.
can be supplementing, but just not yet
Just not
supplementing with
enough.
enough. Yeah.
Okay. Got it. Thank you so much, doctor. I
My
appreciate you.
pleasure. You got it.
Thank you.
Anything
Thank
I could,
you.
and keep us posted. We all love
Yes.
baby dust.
Thank you.
Oh, you got it for sure. Okay. Oh, Flannery had to leave us. We got her. She's good. I'm glad we got her before she left us. So, Darlene says, I am 61 and probably 10 years plus menopause. I have mild osteopenia in my spine. I have never been on hormone replacement therapy. Is it wise to look into versions of HRT with estrogen to mitigate osteoporosis? If so, what should I take? What should I look for in my doctor and test? So yes, yes, emphatic yes, Darlene. So with osteopenia, I would say it's a really good time if you have a provider who you can talk with about starting hormone replacement therapy to get estrogen in to stop the decline that can lead you to osteoporosis. So that's one thing to look at. So estrogen is very good at the prevention of osteoporosis, but it's not treatment for osteoporosis. So it's unfortunately, once somebody has osteoporosis, the treatments are generally much more than just estrogen, but estrogen can slow the progression to osteoporosis. I think that if there were anything we can go back and take back from the last how many years since the WHI study, is the profound effect that taking women off of estrogen has had on bone density and bone health. I think that would be like, if you could change the world, you could change the world in that way. So I really wish that we could go back for those poor women that we've left vulnerable to osteoporosis now in their 60s, and bring them back 10 years ago to when estrogen was basically ripped out of their hands. So I would say emphatically, I do love the idea of low dose hormone replacement therapy for osteopenia. The truth is as I was saying, when we were talking about perimenopause supplementation, the amount of estrogen needed, as we were saying with Flannery, the amount of estrogen needed for perimenopause is sometimes only 25 micrograms, but it's honestly what's been shown to be effective in the protection of bone health when it comes to estrogen. So it doesn't have to be very much. So even if you're not taking hormone replacement therapy for other symptom relief, hormone replacement therapy for bone health can be very low and just enough to supplement that. So it's very important. Also, to be sure, I think we talked about, Tammy had a question regarding calcium. So this loops right into osteopenia and osteoporosis. So calcium is also good preventative medicine for osteoporosis. It doesn't, again, treat osteoporosis well, but it does help prevent osteoporosis. So the goal for calcium supplementation is to get 1,200 to 1,500 milligrams a day, but the amount of calcium that can be absorbed at any one time is only 500 milligrams. So if you do take it in a supplement form, you want to take it in divided doses, no more than 500 milligrams at a time. because the rest, unfortunately, doesn't get absorbed and it winds up in the sewer system. So but the best way to get your calcium is honestly from your diet. So if you are getting a diet that has green leafy vegetables, broccoli, if you are non-vegan and you're getting salmon, shrimp, they have a fair amount of calcium in them. And if you just add up those little amounts throughout the day, they do add up to a pretty good amount, maybe even 50% of your calcium supplementation. And you might just take a calcium supplement to kind of just nail it in and make sure that you get everything that you need. Tammy asked a great question regarding like what form of calcium would you look for? So generally calcium carbonate is what is Tums. So Tums, the calcium carbonate isn't as recommended as other forms because the lowering of your stomach acid with forms like Tums can actually decrease your absorption of calcium overall. So it's not as effective because it lowers the hydrochloric acid in your stomach. So it makes it harder to absorb calcium. So you want to look for things like calcium citrate, which is a much more absorbable form of calcium supplementation. It's really great if you can get calcium in a formulation with magnesium because the two ions together are better absorbed into your system. So definitely getting that calcium, good rich sources in your diet, supplementing with a supplement just to nail it over the top, make sure you're getting all of your calcium. And then that with vitamin D. So vitamin D acts as a hormone to help absorb and activate all the processes to help that calcium get into the bone. So vitamin D, you want to get at least 800 to 1,000 international units. They don't use international units anymore. But you'll look for the equivalent of international units for your, I think it's 250 milligrams of vitamin D is the same as 1,000 international units of vitamin D. You just want to look for that correlation between the two. You can take as much as 4,000 international units a day safely and without even knowing what your levels are to really boost up your vitamin D levels. You want to be someplace in the like region of 75 when you get your blood tested for it to help with your absorb the calcium and integrate that into your bones. And protein, super duper helpful. So protein needs to be bound to, your calcium needs to be bound to protein to make it absorbed as well. So you have to be getting out adequate protein in your diet. So sometimes, in fact, when you're doing blood levels for a woman who has osteopenia, osteoporosis, I'm looking at their total protein, and you can see that in a normal metabolic panel to see if they have an adequate amount of protein dietarily. So if someone has like normal calcium levels and low protein levels, their available calcium is actually quite low, and it's not, and they need to boost that up as well. So those are the things that I think of, just basics, most important stuff. And then of course, you get strength training, that's stress across the bone. You guys are all, know that part. We've been preaching to the choir on that one. You got it. But those are the things that are helpful. So if you certainly have a provider who's open to hormone replacement therapy for your bone health, I think that would be an excellent addition for sure. Absolutely. You got it. So yeah, that was your question, right, Tammy? You were also looking for the calcium formulations. That was a great question. I saw that. I love bone health. It's such an invisible thing that we can have control over, or I should say, we can help have some control over, but we need many, many years. I was actually, it was so sweet. My daughter invited me to do a women's health badge for Girl Scouts. So we talked about women's health and screening with, they're all my daughter's age, so they're 14 and 15 years old. So I was telling them about how important it was to build their bone health now. At this age, we build our maximum bone density by the age of 25, so that they know they can do the things right now to help with their bone health. And it's such a shame to find out so many years later the things that affected your bone health when you were younger that nobody ever told you about. So I wanted to spread the love on that one for them, for sure. You got it. Yeah, you want to, and also, I would say a lot of women unfortunately don't have their bone density screened until they're much older. So if you do have a provider who's willing to screen you younger, it's really great information if you find that you've been diagnosed with osteopenia. You want to be able to make a difference before somebody has osteoporosis. So diagnosing osteoporosis in a 65-year-old woman is okay, but it would be far more valuable to have diagnosed her with osteopenia as a 50-year-old woman, and had the opportunity to intervene before osteoporosis set in. Oh yeah, so Tammy also asked, this kind of loops in as well. Tammy asked about bone density testing. So let me expand on that a little bit. So the DEXA scan that has come up a bunch in the group regarding testing for your muscle mass and for your body fat percentage, it actually is the very same test that is used to screen bone density, very same test. So it's a DEXA scan will give you all that information. So it's a very valuable test if you want to have it done for measuring your body fat percentage. It'll also give you your bone density, and it should give you a graphic reading of your bone density as well, so that you get with your, as well as your muscle mass, which are two very important components together, right? So you want to know that you're properly muscled for your age group, and you also want to know that your bone density is comparable to your age group. So when you get a bone density, it'll give you, for your bones, two scores. One is a Z score, the other is a T score. Your T score is you compared to all women, with the mean being a 25-year-old woman. So all women. And then your Z score is compared to women your age. So both are very important values. A Z score is more often used in younger women, because it's more or less, you're looking at your bone density versus other women your age if you're like premenopausal. So if you're a younger woman and you're in your 40s and you want to see how you compare to other women in their 40s, if you're significantly lower, even if you're not in the osteopenia or osteoporosis range, it is a place where your provider can provide you some guidance to bring your bone health up to the level of other women your age. Or if you are frankly osteopenic or osteoporotic versus the average population, that's where you can make some recommendations. So again, on a DEXA, you're going to see a Z score and a T score, and those are what those two values mean. You'll also, of course, get in a really good DEXA scan your body fat percentage and your muscle weight, your muscle mass, which is also very helpful for all the things that we're looking for with our physique goals, as well as with our longevity goals. So those are really important. I think I got all the things on there. Yes, ma'am. Cool. Yeah, so the very same test would be very helpful. So whether you have it done commercially, I know there's a lot of centers now that are commercially available DEXA scans, but if you qualify, you can have it run through your general practitioner provider to screen your bone density. So that test should be covered by your insurance carrier if it covers exams like that. Okay. So just a couple other things that came up, but I don't know that there's so much questions. We'll read them aloud. So Lorraine just chimed on to add, which I love. So she had, oh, no, I'm sorry. It was Karen who said she was doing much better on the primrose oil tablets, which I'm really happy for. That's really great. She's starting to feel like her old self again. So we had spoken regarding kind of the anger, rage type of symptoms associated with menopause and perimenopause. And my suggestion for Karen was evening primrose oil, which works, you got it, Tammy, which works really well for emotional symptoms throughout perimenopause, premenopausal. So I have women who have PMDD who do really well on evening primrose oil. But so then I'll just add here for Lorraine. You got it. So Lorraine, hopefully you will catch up with us on replay. I don't see you here. So Lorraine, we had another question on a previous call, Lorraine, regarding, I believe it was the use of vaginal estrogen cream for vaginal dryness and vulvar symptoms. So she was saying she took my advice and she went and spoke with her provider regarding a stronger vaginal cream. But in her country, they said there's only one available and it should work. I want to know if there are any other avenues to pursue with this other than the cream. The doctor said to use the prescription for as long as I needed. And I was using for 2 weeks, as it mentioned on the tube, but she said to use it as long as I need until the symptoms disappear. So I will try that for the next time being to see if there's any change. But other than that, I just wanted to ask as I get frustrated here, as they have a very relaxed approach to these issues. So Lorraine, correct me if I'm wrong. When you listen back on the replay, I believe we were talking about vaginal estrogen cream for vaginal symptoms, and you were instructed to use the cream for 2 weeks, it sounds like, but then she said to use it for as long as you need it. I would say honestly, Lorraine, if this is the product that we were talking about, you can fill me in if I'm making the wrong assumption. You can use it after the 2 weeks, twice a week for as long as you want to. And I would say, so with vaginal estrogen creams, just for those who might be listening in who this might apply to as well, vulvar dryness, vaginal dryness, pain with intercourse, or any of these symptoms, urinary tract infections, anything that's associated with urogenital health is well treated with vaginal preparations of estrogen. That can be in the form of a cream, like Lorraine is mentioning here. It's a cream that's placed in the vagina with an applicator, very much like using a yeast infection medication. It started out by using every night for 2 weeks, after which you use it 2 nights a week for maintenance therapy. Over the first 3 months, it makes a significant change in the vaginal symptoms. That benefit can be seen for as long as you use it and can get a little bit better with time. So it only works for as long as you use it, Lorraine, and then the effect will eventually wear off. So how it increases the health of the tissue after a while of not using it, those tissues will become dry again. So I would say, yes, you want to use that product for as long as you need it, which could be forever. Because once you discontinue the cream, the effect will go away as well. So there are also other preparations that you can use vaginally, which we talked a bit about, which can be more effective for different people. So we talked about a vaginal ring, which gives a low level of estrogen to the vagina every day over the course of its use. And also vaginal tablets, which are used essentially the same way that the vaginal cream is. So they're all essentially equivalent products, but some are just maybe a better formulation for one person more than another. For example, the ring is very convenient. You don't have to remember to use it. It's a small amount of medication every day, and that infuses over 3 months, and then you change the device. Or the creams I find are very amenable to more customized therapy. So as I was saying, Lorraine, is what you could do in your case is not, yes, I agree, there's only one dose of the vaginal cream. You can't get any stronger, but you can use it more often. So I have patients use the strategy of using the cream instead of twice a week, but rather 3 times a week to cover their symptoms. And that might be a strategy for you. And you can use the vaginal estrogen products in combination with the non-hormonal vaginal moisturizer products, which you can get over the counter. So some women will alternate between using the moisturizer products with the estrogen products so that they have something more often. So I'm disappointed for you, Lorraine, that she wasn't as flexible with the prescription, or she didn't see more creatively how it could be more helpful. And I'd love to offer more help by being more specific if I can, if the information I'm giving you isn't specific enough, some ways that I could give you maybe some directed pointers to help you master this issue, because it can be a very uncomfortable side effect of menopause. I always say it's a real shame because most people don't have to give their vulva or their vagina much thought on a day-to-day basis. But when it's something that becomes very symptomatic, it can preoccupy somebody's thoughts. And so I can wholeheartedly sympathize with you, Lorraine, that it can be very uncomfortable, very distracting to deal with uncomfortable vulvar or vaginal symptoms. And so however we can help you, or I can help you to optimize this therapy for you, I'm happy to help in any way that I can, because I do realize it can be very distracting and very distressing when that's uncomfortable. So I would say, yes, I agree with her. You can use it for as long as you need to. I would say there's no reason to stop it once you have it. Use it twice or 3 times a week forever, for as long as that you need it to control your symptoms. And again, you can incorporate some of those non-hormonal vaginal moisturizers in between to help optimize your treatment. But Lorraine, if any way that I can be more specific for you, just let me know. I'm disappointed she wasn't more creative for you, but maybe we can come up with something creative on our own together. So I think we did it. I hope that, Carrie Ann, when you listen back, you get something good out of our conversation, and I'd be happy to help in any way I can. Shaniza asked, where's the replay? You guys probably know that answer better than I do. But I think everything else we got on the graphic, which is great. And I will be doing a live in you got it, Darlene, my pleasure. I'll be doing a live in the, which group is that? Is it this group? I'm sorry, I'm really lame. I think it's this group. We're gonna do a live on Facebook and YouTube in 2 weeks. So whomever is brave enough to join me, I know Tanya will be there. She's always there. Celeste, the names I always see, you guys are brave enough to be with me all the time. And I hope that it's been valuable to you in any way that I can be valuable to you guys. You just let me know and I'll be here for you, whether it's on the graphic ahead of time or you just show up and ask me, I'll be here. And I guess that's us. That's a wrap. So have a very good evening. And of course, if you're in the app community, then we have the Ask a Doc group, and feel free to throw the questions in there. It's been working out really well. Very happy with it. And I would say in the other groups, just do like the traditional tagging me, like with my name instead of the TSV coaches. That way I'll definitely find it, and I check my own personal tags. You got it, Tanya. My pleasure. Then I'll check my own personal tags so I won't miss a beat. If you listen up and listen back and you get a question from this call, I'd be happy to answer it. So that's me. That's a wrap. I'm gonna get ready for bed because as we talked about all this sleep, I got to practice what I preach, start my wind down routine, and get ready to hit the bed for my at least 6 hours of sleep. I love you all so much. It was a true pleasure hanging with you, and I'll see you guys really soon. Be good.